Hi, my name is Corey Clark, and this is my case study for DMS 4420. So, patient information. A 72-year-old woman presents to the ER with chest pain. She is 10 days post-op from a total knee arthroplasty. She was a smoker but quit 10 years ago. Laboratory values, a CBC and D-dimer was ran on behalf of the patient and showed a positive D-dimer. Presenting symptoms and additional information, the patient explained that due to her recent surgery, she had been unable to move her leg properly and walking was extremely difficult for her, so she hadn't been very mobile. Since the patient was experiencing chest pain and had a positive D-dimer, a CTPA, computed tomography pulmonary angiography, was ordered on behalf of the patient. A normal CTPA would show an image kind of like this with all of these structures that are labeled: right ventricle, ascending aorta, left atrium, left superior pulmonary vein, descending aorta, esophagus, right pulmonary vein, superior vena cava, and the right auricle. And depending on where you're at in the chest cavity, you'd obviously see different structures. This is just the slice that I chose to label. Here is a coronal chest CT view with some of the same structures that are labeled again: aorta, pulmonary trunk, left ventricle, right atrium, and the left atrium. A pathologic CTPA would show something like this. The one on the left is a CTPA without contrast, the one on the right is with contrast, and we can see a pulmonary embolism in the pulmonary artery there. So based on the lab and imaging results, as well as the patient's recent surgical history, she was diagnosed with a lobar pulmonary embolism. Pulmonary embolisms are classified based on where they are located. A saddle PE is a large clot in the pulmonary artery. A lobar PE is a large clot in the main branches of pulmonary artery. And a distal PE is a clot in the smaller branches of a pulmonary artery. Unfortunately, there is no exact epidemiological data available. However, the incidence of PEs is estimated to be approximately 60 to 70 per 100,000. PE is a blockage in one of the pulmonary arteries in your lungs. The most common cause of this is blood clots that travel to the lungs from deep veins in the legs. This is consistent with this patient's recent surgery history of a TKA. PEs can be life-threatening. However, treatment without delay significantly reduces fatalities associated with PEs. PEs occur when deep vein clots detach and become mobile in the pulmonary circulation. This results in pulmonary vascular occlusion and impairs oxygen exchange in the lungs. The lower lobes are more frequently affected, and bilateral lung involvement is most common. There are two types of medications that are used to treat PEs: blood thinners or anticoagulants and clot dissolvers or thrombolytics. Blood thinners stop existing clots from growing and prevents new clots from forming. A common example of a blood thinner is heparin. Thrombolytics are given intravenously to dissolve clots quickly. Side effects of thrombolytics include sudden and severe bleeding. Typically, thrombolytics are reserved for life-threatening situations. If a patient has a life-threatening PE, doctors may opt to remove it surgically. Another option PE patients have is a vein filter, where a catheter is placed in the IVC and filters any clots that may end up in the lungs. This procedure is reserved for patients who cannot take anticoagulant drugs or is used in addition to anticoagulant drugs when the patient experiences recurrent clots. Pulmonary embolisms can be fatal. Approximately 1/3 of people with undiagnosed or untreated pulmonary embolisms do not survive. However, when the condition is treated and diagnosed promptly, fatalities significantly decrease. The differential diagnoses for pulmonary embolisms include but are not limited to acute coronary syndrome, acute pericarditis, angina pectoris, myocardial infarction, pneumothorax, pulmonary hypertension, and restrictive cardiomyopathy. It is not recommended to biopsy a pulmonary embolism. Patients who present to the ER with a PE will have a different clinical course based on the severity of the PE. In severe cases, surgical intervention and admission to the hospital may be necessary. However, in most cases, patients are placed on an anticoagulant therapy and instructed to follow up with their primary care physician. A review of etiology for this patient and the treatment for this patient. Their PE was most likely a result of the total knee arthroplasty that she'd had 10 days prior. It was most likely caused by the surgery and the patient's immobility. This patient was placed on anticoagulant therapy and admitted to the hospital for 2 days to ensure the pulmonary embolism didn't worsen or provide more complications. She scheduled follow-up with her surgeon and primary care physician to discuss whether or not she should continue with the anticoagulant medications after the pulmonary embolism dissolved. The CTPA protocol includes scout images obtained with the scan being above the shoulders and ending below the diaphragm. IV contrast is injected intravenously with a 5-second delay in a helical scan mode. If the contrast in the main pulmonary artery is less than 200 HU, or if there is significant motion, it must be checked with the radiologist.